All right, yes, we're from ETSU. We want to talk about global warming. Maybe an issue, maybe not an issue, political hot button, so maybe we probably shouldn't talk about it.
How about vaccines? That's not controversial these days.
No.
There's plenty of evidence that says that those are great things, right?
Okay, maybe we'll get away from the controversial,
Okay.
We'll go to patients. And I
Great.
really am impressed with the number. How many of you are patients? Outstanding. Many of us are, unfortunately, as we go through. Patient-centered medical care is really critical. What do you say about that?
Well, I think the question is how much evidence do we need before we agree that this is something that should be the standard? There was a report from the Institute of Medicine more than a decade ago that said this was at the center of how this system should be fixed. And we recently had a Cochrane review that said when this is implemented, that patient care is improved.
So when you look at this kind of thing, you need to figure out why are we up here talking to you. So who are we? Well, we're a series of different organizations. We're at East Tennessee State University, and I can tell some of the animation isn't working, so I'm going to do this in just a minute. The Quillen College of Medicine, founded in 1974, so we're still young. We're still an early medical school, but yet we were founded on rural primary care to really create the physicians that our region, Appalachia, needs, and to be a part of taking care of the communities in that region. So I have the honor of being involved with that College of Medicine and being involved there. When I started in 1992, we had something called the Kellogg Grant. This was a very large grant that was designed to recognize the interprofessional work that we were already doing at ETSU at that time. And so this was 20 plus years ago, 25 years ago now. A really important concept, though, is recognizing that what we were doing then is different than what we're doing now.
That leads us to the Academic Health Science Center that was founded in 1989 with 3 foundational colleges, the Colleges of Medicine, Nursing, and Public Health, and also the Departments of Clinical Psychology and Social Work. After that was added the College of Pharmacy in 2005. And that then laid the groundwork for the 5 total colleges, a total of approximately 17 different kinds of professional learners within academic health sciences. There is the Gatton College of Pharmacy, my alma mater. Please say a little shout out to everybody that's watching back in East Tennessee.
The next thing that happened was a HRSA grant. And so in the Department of Family Medicine, Department of Pediatrics, 2.5 years ago, was awarded a 5-year grant designed to create an interprofessional curriculum for more than just medical students. It's really with a lot of our embedded folks, and to create a self-sustaining model of clinical care in our residencies. We have 3 family medicine residencies that this is housed.
Finally, in 2006, we were recognized as one of the 27 incubator sites by the National Center for Interprofessional Practice and Education, and most recently in 2017 by the American Academy of Health Science Centers, an AIM beta site.
And so when you look at all of that, we're now talking about how we do things. This is a building. Looks like many buildings. You have buildings like this. This is actually the Kingsport Family Medicine Residency. We have 3 of them. This is actually where I started. I was program director for 14 years. And on the outside, it looks like any clinic. It's where things happen. Because we're a College of Medicine and we're a residency, we take care of our learners. We're also taking care of our patients in this area. So when you come together in this place and our patients come in, they're going to be exposed to what seems to be a routine model of what many of us are already doing. And when you look at this looks like the routine model. There's a patient, and there are 2 clinicians working there with them. What you can't tell from the photo, but is really critical, is this is a representation of our interprofessional team. That's actually a family medicine resident, and that's a pharmacy resident. So they're seeing this patient together right now, no attending in the room. This may be a clinic led by our pharmacy faculty. It could be one led by me or some other physician faculty. We can't tell for sure. But the patients know they have a team, a lot of individuals in the room, as well as people who are outside who will be part of the process.
Likewise, on the right-hand side, this is kind of the classic quad of any college that anybody, or any university that anybody would look at and go, yep, that looks really familiar. There are buildings, there's beautiful lawns, there's landscaping. It just looks like the place where everybody learns. And if you look inside, I think everybody would expect that there's the biology department and there's the agricultural department, etc. And the problem is that I think that we can all agree to, and what a wonderful audience to get to speak to, because usually we are trying to convince people, and that's not the case. We're actually talking to people who believe. Thank goodness. So inside of these buildings, This is what we are trying to create. That is a bringing together of these 17 different trainee types, putting them in groups and saying, it's time to work together. It is time to remove silos of care and silos of thought, and saying that the thing that should be at the center of this is how we take care of people, not how we identify ourselves, not the egos that we bring or don't bring, but the things that we should be most centered on, and that is that person's grandmother or that person's mother that is sitting in front of us as a team.
A big part of this is actually community. This is really what we're talking about. Patient-centered medical home, most people roll their eyes. It's one of those acronyms, it's a checkbox, it's non-patient-centered truly. It's about community-based care, but community is not just the buildings, and yet we often think of that. This is a classic community photo, and what's key, as Brian said, is it's who's inside, it's the people, it's the stories, it's that group. Community-based care is really what this is all about. It's part of our mission. But how do we do this? We all talk a good show, but it becomes extremely difficult to actually put this into practice. And that's really what we're trying to do, is to take this as the foundation of what we do and go to that next level. Along those lines, we created something called the bow tie phenomenon. He's wearing a bow tie. You can't see one when I wear it. So whatever we're doing, though, is in the setting of training and practice, and this is really critical. Look at the knot. It's about patients and learners. And then look at what's happening on that side, my side of the bow tie, which is what a lot of diagnosticians and clinicians do. We're assessing things. We hear complaints. We go through symptoms. We ask a whole bunch of questions, hopefully in an open-ended fashion, but not always. In fact, rarely. We usually take control of an interview in about 18 seconds because we want to know specific things. So how do we get there? How do we start thinking through what could be going on with our patients? But at the same time, in this training and practice model are our learners. What is it that they need? We have to be diagnosing their needs and their approaches as well. We have to be thinking through, how do we help them? This is often academic. This is often kind of not with real patients in the first 2 years of a lot of medical and professional training. This is a problem because it's not as critically real as it needs to be. So as we move forward, we look at the knot, pull together, and then we start pushing things out to the other side. And as we do this, we have to be keeping in mind that we're going through a thought process, that somewhere in this knot, our patients and our learners remain central to everything that we do, even though in real life it's life or death.
That brings us to the other side. So one of the things that Reid and I discovered early on in this process, Reid and I started practicing now about 10 years ago. And what I realized was that he spends an inordinate amount of time on that side of the bow tie. And that me and our pharmacy resident and our pharmacy learners spend an inordinate amount of time on the other side of the bow tie. And we figured out if we could actually do this together instead of co-located, but actually in the same room, in the same clinic, and have these discussions together instead of apart, that probably that would be a lot more functional, both for ourselves and for the patient. And what we've discovered is not only do we enjoy this way better, but our learners enjoy it way better too. And that picture that you saw before with the two residents, there is nothing that they enjoy more than getting to collaborate together. They realize that this isn't about, I got to know everything, but I get to enjoy working with someone who knows the maximum at there, and when I get to put those two things together, the egos just kind of crumble away, which is a magical thing.
A problem with this bow tie, though, is that it's still separate. If you're not careful, we're very proud of this analogy, but then we realize I'm over here assessing and doing this, you're over there doing treatment, and yet we're still just co-located. We're not really necessarily doing this together. And this has become the challenge for us, is how do we take this model and then do something different? How do we build on this and try to come up with something that is more unique and more appropriate in getting us to this next point?
So I think we're all familiar with, yes. I think we're all familiar with the Cotter need for change. But just to clarify, this is the Cotter we're actually talking about. So in his 8 stages of change, there are 2 things that we want to bring out and say how these kind of play a central and important role to our discussions on a regular basis. So at our Academic Health Science Center, creating a sense of urgency, that first step for Cotter, to say, you know what, do we all agree that actually something needs to change? So before we go any further, does everybody agree that we need to fix both a health system and an educational system that is horribly antiquated and flawed at its core? So that's the first question. Is there one? And then the second one, I think that brings many people back together is if you can create some quick wins so that you can show that maybe there is validity to this. Maybe there is something that is important to the way we do some structural changes.
And Gladwell builds on that as well. There are a couple of his books that we all often quote and look at. One of them is really about this tipping point concept. When do you get enough people or the right person in the right place at the right time for something to move forward? I think this conference is a great example of that kind of event. And we have several that we can give you in our own institution of when someone was right there that seemed to be that point of moving things forward. In addition, Blink is another way of looking at how we know what we know. It's really critical. Those of us who are masters at what we do often can just say, that is this. And we often don't know why if we start to think about it. This concept of 10,000 hours is really key here. But what's also key, as we heard earlier, exposure doesn't create expertise. So if you just have 10,000 hours of doing things a wrong way or a bad way or a not productive way or a non-interprofessional way, that doesn't mean you're a master at it. So we have to come up with a different way of looking at how do we develop that master as we go along.
That brings us back to what is our sense of urgency? I'm sure that everybody in the audience today remembers a trial that was recently published in Lancet. I'm not quite sure why it was published in a European journal, because it was studying the United States healthcare system. But as a result, there are 4 numbers I want you all to leave with today: 3, 4, 7, 4, 7, and 250,000. That study said that medical error was the number 3 reason for mortality in the United States. Just grasp that for a second. That means behind cardiovascular disease and oncology, we are the most efficient group that kills people in our system. Congratulations. That equates to 4 747s dropping out of the sky every single day, every single week of every single year. What that means is 250,000 people in our system die every year as a result of errors that we do. Going back to the Institute of Medicine's report, it said that if we communicated better, if we removed our egos, if the teams came together, maybe those numbers might be different. So what are some of our early wins that we thought were happening? So this is a picture of the first cohort that we put through now about 5 years ago at ETSU. This is a simulated refugee experience where we brought together all of these different learners. And we put them into what we called a refugee experience. We had actors and various people playing the role of a refugee coming into a camp, gave them little to no direction. This was one of our learning experiences. Learned that maybe they needed to know more about that process before they got there than they were given. That led us to a time where we paused, reflected, changed, and brought a new cohort in 2 years ago. This is our most recent cohort that went through. Just graduated a few months ago. We're very happy and pleased about. In this group, what we learned, maybe we needed to put them together and leave them together. So we created 6 teams from those 17 different groups of learners and mapped them across a 2-year experiential process where they were trained in the 4 domains of interprofessional education and then sent out to the community to make a difference.
When you look at this process of what we did, we took something that didn't work. We thought it was a win, but it probably wasn't a great win. We then put our students together into a group, and then we brought those students together into rooms, and these rooms allowed us to begin to do that process, that incubation of what we did with our students. Looks like typical learning. We hope it's not. It's a lot of adult learning. It's a lot of small group. It's a lot of interactions. These are pictures of students from all walks of the different health science center colleges. And you can't tell from anything. There are no markers of who is what. They created their own identity. That bottom left is actually my group, Impact Bear. Don't worry, Impact was a cool acronym. Don't worry about it. No one remembers what it meant, but it was cool. And we were the Bear group. They got a Facebook page. We're still together, even though this group is now gone. I'm going to miss them terribly. Brian's group would meet routinely together. A sense of community occurred with these learners. And it carried through in a way that we did not expect. It's a true win. The second group that's going through is different, as all groups are, as all kids are. And we're trying to figure out what do we need to do different, or do we just accept that sometimes it is different. But this all culminated in the end of this first cohort of 2 years together with a very special moment. The deans have committed to this time for us.
And I think it all ended with sort of a "we told you so" presentation from a local health system executive who came in and gave the keynote address to our graduates. You can see there cords that we provided to them to give a sense of ownership of this program. He is the chief development officer of our largest health system and basically said to them, "You are exactly what we will be looking for in the future when we hire." That brings us to where we're going. So Building 60 is our future. You can see this beautiful old historic building that sits on the VA campus where we reside. These are pictures that are within the last couple of months.
Yeah.
This was the quartermaster's building when the VA was at the turn of the century. We think that's really symbolic because the quartermaster was where all things came through. What we hope that this becomes is the building, the structure where all educational processes of simulation for interprofessional education will come through. The new model that will be instituted in 2018 will have a trifold process. That will be a didactic portion that provides the importance of team building, then simulating a place of safety in patient education and patient care, and then sending those people out to an arena that looks just like the thing that we simulated, so it feels like they just did with the safety net provided.
This is what's key for a lot of these pieces we put into place. The HRSA grant, we're starting year 3, is embedded in our family medicine residencies where we already have psychologists, pharmacists, social workers, and we're moving PT in. We're trying to find everything we can. We had nutrition. We are trying to create that model because if a learner does this and then goes out and doesn't see that, you miss the point. They need to demand it. Actually, we're asking our learners to go out when they're looking for residencies and say, "Where's your interprofessional stuff? I don't see a bit of it there." We want to create a group that is demanding to see this change to help move all the pieces in place. So that's really one of our goals and one of our challenges is how do we get to that point in what we're really doing with our learners and what we're really doing with our patients. And when you look at this process, it really is sort of a culmination of figuring out where have we been. We all kind of have an idea. How many of you think interprofessional stuff's good? Okay, good, thank you. That's to wake you up a little bit. So we all believe that this is a very good thing, and yet we also talk about it a lot. We all check the patient-centered medical home component. We all can show how and what we do. And the trouble with this is it's not enough. In a TED Talk, Simon Sinek basically came up with the golden circle. And we see this as a real model for what we're trying to do. Our why is because it's the right thing to do. It's because we know this is correct. We have the evidence. We've put in well over 10,000 hours, sadly, at not doing it well. And so our challenge is how do we take those next steps toward true mastery and to do this differently? How can you know, who are your tipping points? Where are you in your mastery level? Where is your why for this process? We all have a lot of hows and whats, but you can't do that if you're not at the middle of that circle, if you don't know your core, and if you aren't ready to move that forward. That's really what we're trying to do in our institution to get to that point. And we're honored to get a chance to share some of that with you and look forward to the panel.
Thank you.